One of the most prescribed drugs in the neonatal intensive care unit or the NICU is going to be oxygen. And there are very many modalities that we can actually administer this oxygen. And one of the most important when it comes to neonatology is CPAP, or what we call the Continuous Positive Airway Pressure. Now, in this video, we're going to look at CPAP in detail, cover all the theoretical aspects that are very, very important that you have to understand. And then in the next video, we are going to look at how to set up a bubble CPAP. And this is the CPAP that is most commonly set up in limited resource settings. So my name is Benjamin. This is Med One Pager, where we get a high yield concept, put it on one page, and then discuss it in detail. If you have not subscribed to the channel, but you're someone who likes to understand things in great detail, then I urge you to subscribe to the channel. And let's get started. So CPAP is a non-invasive respiratory support. This means we are not intubating. Remember, there is what we call intubation, where a tube is put into the trachea and then oxygen delivered via a ventilator. But with CPAP, it's going to be non-invasive, and we're going to deliver a constant positive airway pressure throughout the respiratory cycle in a spontaneously breathing neonate. And this is very important because if someone is not breathing spontaneously, then they cannot qualify for CPAP. So the positive airway pressure is very easy to understand. Imagine you're blowing into a balloon and then you deflate it. When you blow into that balloon, you are giving, that is what happens during the inspiration. And as you expire, all the air goes out. But if you leave a positive airway pressure, if you leave some air inside, what CPAP does, that balloon will not completely collapse. And the goal of that is that you want to maintain a lung volume, improve oxygenation, and reduce the work of breathing. And this eventually will reduce the risk of intubation, because remember, if someone has an increased work of breathing, especially a neonate, they're going to use all their energy, they're going to get weaker and weaker, and then eventually they'll start failing to respire. And when they fail to respire, then you have no choice but to intubate them and put them on a ventilator. So why do neonates need CPAP? And that is because of the preterm lung problems. In the previous video, we looked at the preterm and saw all the diseases that affect the preterms. Now, a recap of that is that the preterms have decreased surfactant. Surfactant is what reduces surface tension within the lung, within the alveoli, the functional units of the lungs. So when surfactant is low, you are going to have an increase in the surface tension. And when someone breathes out, like a balloon, the alveoli are going to collapse. And when they collapse, their compliance is going to get worse and worse. Compliance is the ability to expand and then to go back down. That is going to continue failing and failing. And eventually the lungs may actually collapse and we have what we call atelectasis. So when we have a decreased functional residual capacity, this is also something that is physiological in neonates. They have a decreased functional residual capacity, and therefore this makes them have a poor oxygen reserve. And that means when they have episodes where they are not breathing well, there is rapid desaturation. Then also when you look at their chest wall, the chest wall is weak, so it is compliant. It does not stand on its own. And this is going to lead to chest retraction that increases the work of breathing. And as we said, as the work of breathing increases, there is a high chance this neonate is going to go ahead and get tired, they'll stop breathing and need mechanical ventilation. And mechanical ventilation does not come with few side effects. As you have seen, it's already an invasive way. So there are risks of infection that are higher when compared to non-invasive ways. So the CPAP effects is that CPAP is going to increase the functional residual capacity by keeping the alveoli open at all times. It is going to decrease the rate of atelectasis. It's going to increase the lung compliance. It's going to decrease the ventilation perfusion mismatch. Remember, the blood flow to the alveoli never changes. If you have some alveoli collapsing, they are still going to be perfused. And that blood will go back to the heart, but without picking oxygen from that alveoli. So you are going to have a ventilation perfusion mismatch, whereby the perfusion is good, but the ventilation is poor because there is no gaseous exchange in those collapsed alveoli. CPAP helps reduce that, and then it stabilizes the chest wall because it's leaving a pressure inside there. The chest wall is going to stay up on that pressure. It's not going to collapse in on the lungs. And then it also splits the upper airway, because the upper airway is made up of soft tissues. It's made up of things like the pharynx and stuff like that. That is soft tissue, and sometimes it may collapse. So as you give this CPAP, it's going to push this upper airway upwards. And this is something that we employ also in adults who have obstructive sleep apnea. They are put on CPAP. The CPAP tries to keep that opening open. So we have two modes of giving CPAP. We have the prophylactic CPAP, or the early CPAP, and then we have the rescue CPAP. So prophylactic CPAP is the CPAP that we give to any newborn, high-risk preterms that are born less than 32 weeks. So any neonate that is born before 32 weeks, we think they need what we call a prophylactic CPAP. So when they are born, whether they are breathing well or not, we are going to put them on CPAP immediately. The timing is immediately after birth. That is for the prophylactic CPAP. Then the rescue CPAP is the CPAP that we shall give after respiratory distress has developed. And this can be in conditions where we have respiratory distress syndrome, that is hyaline membrane disease, or when we have no surfactant. But it can also be given in areas where we have other things coming in. A child develops a pneumonia. When they get the pneumonia, they aren't able to breathe well. And then you go ahead and give them some CPAP to see that they can breathe better. So the purpose of the prophylactic CPAP is to prevent lung collapse, while the rescue CPAP is there when you already have an established disease. So it is helping you treat that established disease. When you look at who is used in the prophylactic CPAP, or the early CPAP, is used in high-risk preterms. Those are the ones less than 32 weeks. Whereas the rescue CPAP is going to be given in infants with respiratory distress, or who are already having hypoxia. This is a baby who may come in, they have been home breathing well, and then after 1 week probably they are turning blue, they have a severe respiratory infection. You will give them the rescue CPAP. Then the benefit of it is that it maintains the functional residual capacity early and reduces ventilation. That is mechanical ventilation. That is if you use the prophylactic CPAP before the alveoli go ahead and collapse. Now, the rescue CPAP, when you give it, it helps recruit the collapsed alveoli because it's going to maintain this pressure inside there. And sometimes that is going to help recruit more alveoli that were actually collapsed. The modern approach is that the prophylactic CPAP is preferred for high-risk infants. You don't wait for them to desaturate. And the rescue CPAP is used when the symptoms appear. So that we have looked at the two modes of giving CPAP. Now I want us to look at the indications of CPAP. The main indication is going to be respiratory distress syndrome, and that is going to be due to a surfactant deficiency that causes the alveoli to collapse. But we have other diseases of the newborn or even the neonate that may require this, and this we have the transient tachypnea of the newborn. And this one is an interesting one because it's going to occur mostly in children who are born via C-section. And we shall make a video about it where I'll explain why. But it lies within the mechanism of labor. When the child does not pass through the rigid birth canal to push that fluid out of their lungs, the residual fluid is going to cause a transient tachypnea because the lungs are still having that fluid within them. Then we have apnea of prematurity. This is common in the preterms, and we looked at this in the video about the preterm. We have post-extubation support. This is when we are weaning someone off the ventilator. Sometimes we need to keep that positive pressure to see that we don't have rapid desaturation, and then later wean them off the CPAP to free flow oxygen, and then eventually on their own. Mild pneumonia, we may need to actually use CPAP. And mild pulmonary edema, also CPAP would be good, because if the pressure in the alveoli is high at all times, then we can kind of prevent more fluid leaking into the alveoli to cause the pulmonary edema. Then we have the contraindications of CPAP, and these ones are very important for you to understand before you actually go ahead and prescribe CPAP. So we have the absolute contraindication, which is severe respiratory failure, needing ventilation. When someone needs ventilation, CPAP is not going to help. once they cannot move their chest, once they cannot breathe on their own, or they do not have that breathing, the ability to breathe, then CPAP is contraindicated. Go ahead and intubate them if you can. Then recurrent severe apnea is going to be an absolute contraindication, because this means this person is having cessation of breathing for a while. If they're not breathing, CPAP is not going to change that. Cardiovascular instability is important to understand, because CPAP increases the intrathoracic pressure, which means it's going to reduce the amount of blood that is coming back to the heart. If this baby is having shock or something like that, and you are again increasing the pressure within the intrathoracic cavity, you're reducing the amount of blood coming back to the heart, they're going to get weaker and weaker. The heart is going to get less blood, the cardiac output is going to worsen. And then untreated pneumothorax is a very important contraindication, because if this person has a pneumothorax and you put them on CPAP, the CPAP is going to push more air into the pleural space, and when it pushes more air into the pleural space, it can easily convert the pneumothorax it can convert that simple pneumothorax or the untreated pneumothorax into a tension pneumothorax, which is actually a cause of death. It's going to lead to shock and patient is going to die. So we have the relative contraindications, things like upper airway obstruction. Sometimes someone maybe you are putting the nasal bronchs on, but the upper airway is obstructed. So there's nothing there that you can do. Either you intubate them or you go for a tracheostomy. Congenital diaphragmatic hernia. This is because as you give this CPAP, sometimes you may push the air. CPAP causes the stomach to swell, and then it's going to cause that herniation to occur. Then if someone has severe abdominal distension, then also you don't want to give them CPAP, because we are going to look at the complications of CPAP, and one of them is the CPAP belly, which is due to accumulation of air in the stomach. So we have the types of CPAP. We have the bubble CPAP, and this one is the one that is commonly used in limited resource settings, and it's the one I'm going to show you how to set up in the next video. It's going to be really short. I'll keep it short and sweet. I'll try to just go ahead and explain the important things. Where you put the tube, the expiratory limb, the limb that takes expired air away, into water at about a depth of 5 centimeters to give you the pressure. Then we have the ventilator CPAP, which is provided by the machine, and this one is good because you have more precise control. You just say that I want 5 centimeters of pressure of water as the pressure, and then that pressure will be delivered. Then we have the variable flow CPAP, and this is where you actually have different pressures, positive airway pressures, different within the different phases of breathing during inspiration and during expiration. During expiration you don't want a very high pressure, and during inspiration, so we have the peak expiratory pressure and things like that. And that one is also going to be delivered by a machine, and it improves the work of breathing, because if you're having a different pressure between inspiration and expiration, you're going to breathe a bit easier than someone who is having a constant pressure throughout both cycles, when the pressures are going to vary so much within the respiratory system. So we have the complications of CPAP, and one of them is nasal trauma because of those prongs, and you have to make sure that you have the correct size of prongs and check the skin. Then we have CPAP belly due to air swallowing. When you put this tube in the nose, it's not going to choose where to go. It can go through the esophagus, it can go through the trachea, and this can cause abdominal distension. Most of the time we manage this with an orogastric decompression. So a tube is passed through the mouth and then to the stomach, and it will try to decompress this neonate. Pneumothorax, and pneumothorax can occur due to the high pressure. The high pressure can rupture the alveoli and air leaks into the pleural space. And if you continue giving the CPAP without noticing this, you can get a tension pneumothorax that eventually can lead to a cardiac arrest. Hemodynamic effects and increased intrathoracic pressure is going to decrease the venous return, and that is going to decrease the cardiac output. And we already talked about that. Oxygen toxicity is something that is very important to understand, because excess oxygen can cause the proliferation of retinal vessels and cause retinopathy, and also it can cause the lung injury. And sometimes we have persistent pulmonary hypertension in children who have been on oxygen for a long time. So sometimes we give CPAP as well as surfactant, And these ones are used together in preterm respiratory distress syndrome. And we have two protocols that are very important for you to know. We have the INSURE and then we have the LISA. The INSURE is simply you intubate that patient. After intubating, you go ahead and give them surfactant and then you extubate them and put them on CPAP. The LISA, there is no intubation. It is less invasive, so you don't intubate, but you give the surfactant while maintaining the CPAP. And the goal is to reduce mechanical ventilation exposure because, again, it's invasive and there are very many risks, including ventilator-associated pneumonia and things like that. So when we are weaning babies off CPAP, there's a criteria that we have to know. The baby has to be stable or should have stable oxygen requirements. There should be minimal respiratory distress. You don't want to remove a distressed baby. You are seeing literally they're having retractions, they're having tachypnea, they're breathing very badly, and you want to wean them off CPAP. That's not something you do. You wait for them to calm down, so that they're breathing a bit more normally, and then you go ahead and start the weaning process. And they should have few apnea episodes. So typically, you are going to reduce the CPAP pressure to less than 5 centimeters of water. If you reduce the pressure to less than 5 centimeters of water and this baby is still breathing well, then you are going to consider that. Sometimes we have the fraction of inspired oxygen. This is the amount of oxygen that we are providing through that tubing. Now, most of the times, we are not giving, all the times, we are not giving 100% oxygen. We are giving a percentage. And the thing is, oxygen is also toxic. You don't want to give a lot of it. So if the fraction of inspired oxygen, the amount of oxygen you're delivering to this neonate is less than 25-30% and they are able to still saturate well, then we go ahead and start the gradual reduction. So we are going to reduce the pressure. So most times you find that the typical CPAP is given at a pressure between 5 and 8. So you're going to reduce it, and when you reduce it to less than 4 centimeters, then you can give them a room trial of air if they are able to still breathe well. If they're in room trial, sometimes room air trial, you may realize that they're not actually saturating well, but you put a nasal cannula only without CPAP and you realize that they are getting better. Then you can keep them on a nasal cannula and then you keep reducing the pressure of oxygen, you keep reducing the pressure until this neonate is able to breathe on their own. So I think I've covered a very, very important topic, and I hope now you understand how we manage with CPAP in the NICU. The next video is going to be about how we set up a bubble CPAP. It's going to be a very short video, and I hope to see you there. My name is Benjamin. This is Med One Pager. If you have not subscribed to the channel, make sure you have subscribed, because we are still going to do a lot when it comes to the neonatology section.